You all a very good morning. I had to get you all up out of bed early because it's 9:30 at night in the US in New York, and because of the time difference, you people had to start at 7. But I think that's good because you'll finish by 8 and get ready to go to the wards, and that would be perfect timing. And this won't come in the way of your rounds. So Sunita wanted me to talk to you about pulmonary hypertension in association with congenital heart disease. And that has been an increasing problem over the times, and I think it's a very important topic at this point in time. So how do we define pulmonary hypertension? Pulmonary arterial hypertension is a cardiac catheterization definition, and the definition in congenital heart disease is not really different from pulmonary arterial hypertension by cath with any other etiology. Increased mean pulmonary artery pressure more than 25 millimeters mercury at rest. Normal pulmonary capillary wedge pressure less than 15 millimeters of mercury, and increased pulmonary vascular resistance more than 3 Wood units. This is from the consensus definition. In some of the recent definitions, they do not use the 3 Wood units, the PVR, but they just use the mean pulmonary pressure and pulmonary capillary wedge pressures. Now, what's the clinical classification of pulmonary hypertension? The slide that you just see right now is the Dana Point classification, which was from 2008. I have to tell you before you do too much with this slide that a new version and a new classification is going to come out very soon, because there was a World Congress of Pulmonary Hypertension just this year, 2 months ago, and they came up with a totally different classification for pediatric pulmonary hypertension. And there is a little more importance to congenital heart disease than there is in this Dana Point. But as of today's date, this is the most updated classification that we have available. So if you look at this classification of pulmonary hypertension, Group 1, this is called WHO Group 1, is pulmonary arterial hypertension. Now, if you look at it, it has all kinds of conditions thrown into this group. And the one common pathway for this is when you do a lung biopsy in these patients or an autopsy, it really looks the same. So the pathophysiology at the lung level is similar for all of these conditions which are grouped under Group 1, pulmonary arterial hypertension. Group 2 is pulmonary hypertension due to left heart disease. Some of our congenital heart disease patients do fall into this category, but I'm not going to really discuss this category as of now. Today I'm only going to talk to you about pulmonary arterial hypertension with congenital heart disease, this group which I've highlighted in yellow. Group 3, pulmonary hypertension due to lung diseases and or hypoxia. If you think about Group 3, the thing that comes to mind is are these adults with interstitial lung disease and chronic obstructive lung disease. However, remember, in these days of improved neonatal care, the patients with bronchopulmonary dysplasia or chronic lung disease of neonatal origin is an increasing population as more and more smaller and smaller babies of lesser and lesser gestational age are being kept alive. The other important subgroup in pediatrics in this group are the patients with congenital diaphragmatic hernia who happen to have pulmonary hypertension. In the new to-be announced classification, WHO classification, this Group 3 is going to be kind of broken up because some of these patients with chronic lung disease and some of these patients with diaphragmatic hernia have features of Group 1, have features of pulmonary arterial hypertension, and they seem to respond to those kind of drugs. So they don't truly fit into this WHO Group 3. Group 4 is thromboembolic pulmonary hypertension. It's not that commonly seen in the pediatrics age group, but it's not something that you have to completely rule out, because we do see few patients every year with thromboembolic pulmonary hypertension. Some of them have a hematologic etiology. Many of them we do not know why they have thromboembolic pulmonary hypertension, but they have to be treated with anticoagulation. Group 5 was a group with unclear multifactorial etiology, where it was everything that did not fit in the first 4 groups were put. If you look, hemolytic anemia was in group 1 and hematologic disorders are in group 5. All of these problems will be remedied in the next classification. So what I'm going to talk about is the congenital heart disease, which is part of group 1. Now, when you look at congenital heart disease and pulmonary hypertension, we have to classify it further because there are many congenital heart diseases which can be associated with pulmonary hypertension. So when you look at shunts, you look at type of shunt, the size of the shunt or the dimension, direction of shunt. So not everyone has a completely right to left shunt. So you could have left to right, you could have right to left, you could have bidirectional shunting. Associated abnormalities and status of repair. And as we go further in this talk, you'll see why that's important. So what are the types of shunts that we commonly see which are associated with congenital heart disease and pulmonary hypertension? 1, simple pre-tricuspid shunts. Now, what do we mean by pre-tricuspid shunts? Basically, shunts at the atrial level. So you could have a secondum ASD, sinus venosus ASDs, primum, and total or partial unobstructed anomalous pulmonary venous return. Here the key word is unobstructed because once they get obstructed, remember by definition, pulmonary arterial hypertension is with normal pulmonary wedge pressures. So once you get obstructed pulmonary venous return, it's post-capillary. So you fall into group 2 pulmonary hypertension. Types of shunts associated with pulmonary hypertension other than pre-tricuspid are the simple post-tricuspid shunts. So these include the ventricular septal defects and patent ductus arteriosus, as well as the AP windows. You should also remember combined shunts, which are the ASDs and the VSDs together, or VSDs and patent ductus arteriosus. Complex congenital heart disease, including the endocardial cushion defects, truncus arteriosus, single ventricle physiology with unobstructed pulmonary blood flow, and we'll talk about this further later on. And a very important group is transposition of great arteries with or without VSD and with or without patent ductus arteriosus. So if you look at an adult, not every adult with congenital heart disease or a shunt has pulmonary hypertension. So what is, for purposes of simplicity, you call a small defect as an ASD less than 2 centimeters in an adult and a small VSD. Now those defects are not supposed to have pulmonary hypertension. So if you have a tiny little VSD and a severe pulmonary hypertension, then you would have to think, is this a patient with idiopathic pulmonary hypertension who happens to have this VSD? Or if you have a 7-year-old child with an ASD and systemic pulmonary hypertension, again, you have to think this is an associated defect along with probably idiopathic or what used to be called as primary pulmonary hypertension. The next category is persistent left to right shunt. So any patient with moderate to large sized VSD or PDA is going to have systemic pulmonary pressures, correct? So you have equal pressures in your right and left ventricle. But you have to remember there's a difference between high pressures and high pulmonary vascular resistance. So a baby who is 6 months old with a large VSD or a large PDA is going to have pulmonary pressures which are equal to systemic pressures. But that does not make them inoperable because the pulmonary vascular resistance is lower than the systemic vascular resistance significantly, which is why they have the left to right shunt. So these have to be differentiated from the Eisenmenger syndrome, where the pulmonary vascular resistance equals the systemic vascular, or it may be even more than the systemic vascular resistance, and the shunting is right to left. So you have to remember the difference between pressures and resistances. Eisenmenger syndrome was classically described in VSDs, but we generally call anybody with very large shunts which are bidirectional or right to left as Eisenmenger syndrome, just out of convention. The next category, and a very important category, is pulmonary hypertension after corrective surgery. So these may be patients with no shunts or very insignificant residual shunt lesion. So having a shunt is not an explanation for why they have pulmonary hypertension. It may be that some of these patients were operated too late and they should not have been operated, and they had already developed irreversible pulmonary vascular disease at the lung level and hence have escalating pulmonary hypertension. So you've basically taken an Eisenmenger VSD and converted them into a physiology similar to PPH or idiopathic pulmonary hypertension. There are also others where surgery was performed at an appropriate time. Say you have an 8 or 9 month old baby who had a VSD which was closed. It's not really that late that the VSD was closed, but this child may continue to develop pulmonary hypertension, which is pretty severe and much more severe than if the shunt had been left alone. So these are patients that make us wonder whether these people had propensity for developing pulmonary hypertension regardless of their shunt. So they are somewhat similar to this group, which has small defects but severe pulmonary hypertension. So how do they present in adults? The ones with small defects and the ones with pulmonary hypertension after corrective surgery are very similar to idiopathic pulmonary hypertension. The ones with persistent left to right shunt are our children before surgery who are operable really. So they have no cyanosis and they have mild to moderately elevated pulmonary resistance, and depending on what the resistance is, they are operable or not. Eisenmenger syndrome are severely elevated pulmonary arterial resistance with bidirectional or right to left shunt, cyanosis, and multi-organ disease secondary to this. Now, why is this so important? All over the world, there's a changing prevalence and age distribution of congenital heart disease as there's better and better, earlier and earlier diagnosis and also treatment for these patients, and more people being kept alive. So in the past, it was often that somebody with congenital heart disease did not get operated on time and they probably died either from the disease, from Eisenmenger syndrome, or complications thereof. Now, if you look at increasing prevalence of pulmonary vascular disease, this study is from Canada. So this is the different time intervals when they looked at the population. If you look in the previous millennium, these are the yellow. Above the age of 40, there was barely anyone with congenital heart disease alive, and the incidence kept going down over time. If you look in the modern era, at 1 to 12 years, it's about the same prevalence of congenital heart disease as in the previous era. But if you look at the next generations, you can see the purple shows increasing numbers of people with congenital heart disease being kept alive. And this is from the Canadian general population. So this is a very important group that we are going to be dealing with over time now. The REVEAL registry was a registry which included patients with all kinds of pulmonary hypertension around the country, and 1,280 patients of associated pulmonary hypertension were enrolled in REVEAL. If you look at the percentage of population with pulmonary hypertension, and this is really all age groups here, you can see about 20% of them had congenital heart disease and pulmonary hypertension. So now, what is Eisenmenger syndrome? Because these were the ones which were called as CHD and pulmonary hypertension in this REVEAL category. Eisenmenger is defined as pulmonary arterial hypertension with increased pulmonary vascular resistance, reversed or bidirectional shunt, which could be at the ventricular, atrial, or aortopulmonary levels. In 1897, Victor Eisenmenger described the first adult patient with the findings of cyanosis and shortness of breath, and he didn't call it Eisenmenger syndrome. He just described this patient. Paul Wood then later on went to describe the whole pathophysiology, and in honor of Victor Eisenmenger, gave him the credit and called this condition as Eisenmenger syndrome. Again, Paul Wood described a patient with VSD, and now we just use this for any major shunt. So what happens in Eisenmenger syndrome? Very early, there's all left to right shunting. And this is with any patient with a large shunt. So there are signs of high output failure and hyperdynamic circulation. Now, as there's hyperdynamic circulation, the shear stress leads to increased pulmonary vascular resistance. And later on, there's reversal of blood flow through the defect with cyanosis and heart failure. So if you look at pre-tricuspid shunts, there's a difference between what happens in ASDs and what happens in VSD, PDA, and AP window. So we'll just separate them into pre and post tricuspid shunts because what happens physiologically can be separated into these two groups. So if you look at the ASDs, which is on this side, there's a much slower rate of increase in the pulmonary disease. The right ventricle response to the increasing pulmonary vascular resistance resembles what happens with the idiopathic group because there's dilatation, hypertrophy, and systolic heart failure. This is for some reason seen much more with sinus venosus ASDs, suggesting that there might be some genetic link between these two conditions and between idiopathic pulmonary hypertension possibly and having a sinus venosus ASD, because physiologically a sinus venosus ASD is not that much different from a, say, a secondum ASD without any other associated condition if the pulmonary veins are okay. But for some reason these seem to have earlier pulmonary hypertension development. Now look at post-tricuspid shunts, large VSDs, PDAs or aortopulmonary windows. Structurally, the pulmonary vascular changes are much earlier, but then this is because of the high pressures and flows, and there's very rapid progression of disease in these patients. Changes in the molecular level and at the arteriolar level occur within the first year of life, and very often by 2 years, many patients become inoperable with large VSDs or large aortopulmonary shunts. In post-tricuspid shunts, 50% of unrepaired VSDs or PDA develop Eisenmenger syndrome into adulthood. In pre-tricuspid shunts, only 10% of unrepaired ASDs in childhood and about 25 to 50% of adults have significant pulmonary vascular changes. So very often we see 70 and 80-year-old adults with ASD which got diagnosed when they went in for a coronary angiogram or evaluation for cardiac problems, and they find they have ASDs. And they may still be operable because they have not developed irreversible changes. So ASDs with early development of changes are something that we see very often in the Indian subcontinent and a lot of patients of Indian origin for whatever reason. Down syndrome is an added risk for advanced pulmonary hypertension, as well as complex defects like truncus, arteriosus, transpositions, and AV canal. It's been seen that 100% of unrepaired complex congenital heart disease develop pulmonary hypertension by the end of infancy. So this is just a diagrammatic representation of what happens in a VSD. So this is just a heart picture where this is blue blood in the right side of the heart and oxygenated blood on the left side. This is very early, and QP-QS is 3:1, and pulmonary vascular resistance is normal, and that's why there's this big left to right shunt. So this child obviously will present with severe failure to thrive, respiratory symptoms, difficulty in feeding, and irritability, sweating over the head, classic signs of heart failure. If you do a lung biopsy, there's not any significant changes in their arterioles. The next stage now, still left to right shunt, but your QP-QS has reduced and the pulmonary vascular resistance has gone up, but it's still less than the systemic resistance. And very early changes start developing in the histopathologic changes in the lungs. The next stage is a later stage where you see more advanced changes developing and the plexiform lesions forming in the arterioles. And if you see there are layers of muscle increase over here, the pulmonary vascular resistance is still less than systemic vascular resistance. This shunt is still left to right, but very minimally so. And this is the honeymoon period, where the family might come and tell you that in the first year of life, this child never grew, he was the tiniest, he was the little runt of the family, and was always sick, always irritable, pain in the neck baby. But by the time this baby turned 2, he was just the most wonderful child. He started growing, no more infections, no more, he managed to be running around, and he was just perfect. He never fell ill. And that is really what we call as the honeymoon period. And when this happens in a child who is very symptomatic, you have to really start getting worried as to whether you've missed the bus. And is this baby going to be operable anymore? The next stage is the end stage, where your shunt is bidirectional, PVR is more than SVR, and QPQS is less than 1. And this is the stage where the severe histopathologic change is seen. This again is another way of looking at it. Here the PVR is less than SVR in the leftmost diagram, and here irreversible changes have developed. So this is the borderline period that we are all looking at and hoping that we can reverse and bring them to this side rather than and prevent them from going to this side. So what are the histopathologic changes associated with congenital heart disease and pulmonary hypertension? Extension of smooth muscle cells into the peripheral pulmonary arteries, medial hypertrophy, formation of plexiform lesions, and ramification of the pulmonary artery tree. What are the signs and symptoms in Eisenmenger syndrome? Initially, the cyanosis occurs with disease, but as the disease progresses, right to left shunt increases and cyanosis becomes profound with increased hematocrit. Due to chronicity, many of these patients self-restrict and they're completely unaware of symptoms. So the same child who was a runt as a baby, who was always sick, started feeling better. And then once he started feeling better, this child was not operated. The parents thought that the hole closed miraculously, and he starts restricting. So he never gets into games and sports like other children. He's always quiet and takes part in activities which don't require too much exertion. And many times people think this child has no symptoms, but this child has no symptoms because he's not active. Soon, over a period of time, hypoxia occurs and the shunt becomes right to left and they start looking blue. The hypoxia leads to vasoconstriction and there might be VQ mismatch seen. Because of persistent cyanosis, there is hyperviscosity. So over a period of time, they start developing clubbing. There are headaches. There may be visual problems. There may be platelet and coagulation abnormalities, bleeding disorders, altered viscosity leading to thrombosis. So some of these patients have hemoptysis and some of these patients have pulmonary thromboembolism. There may be significant systemic complications in the kidney, in the liver, in the CNS. However, it's been seen that survival is much more favorable for Eisenmenger syndrome than for idiopathic pulmonary hypertension. And there's a very interesting conjecture on this. Why is survival more favorable for these patients? One is we know that these people have a hole in the heart. So because of the hole, as the pulmonary pressures go up, as the right-sided pressures go up, there is a pop-off. So your blood goes right to left and the RV doesn't completely compress the LV. If you look at idiopathic pulmonary hypertension without a hole, as the pressures go up on the right side, the septum starts bowing more and more into the left side, and they develop left side. They just drop their cardiac output, and they may have syncopal episodes or drop down. But what happens in the Eisenmenger patient? They have remarkable adaptation in the right heart, and the right heart is more like a fetus rather than a typical adult heart. And this is because if you think of a fetus, it goes through those 9 months of gestation with systemic pressures on the right heart. And then what happens to the fetus when it's born and has a normal heart? The pressures drop down to 1/4. But if you look at these patients with a large VSD or a large PDA, the pressures never dropped. So the right heart never changed its phenotype to being 1/4 of the systemic pressures. So it remains like a fetal heart and seems to manage better. Unrestrictive defects have increased wall thickness and they have arterial hypoxemia, which is also similar to what you see in the fetal phenotype. So this RV is primed for a lifetime working at the systemic level. And perhaps that's the reason why the Eisenmenger patients do not start failing. So there might be some rationale to looking at these cellular adaptations, and maybe this could aid in treating failing right ventricles and other type of pulmonary hypertension. Just convert their signaling into some kind of fetal phenotypes. This is an attractive idea, but we do not know if this is feasible. So going back to the REVEAL registry, which is really the largest registry giving us information, the 4-year survival from enrollment to 4 years in Eisenmenger syndrome was not that much different from idiopathic. And this is odd. This is contrary to what is the conventional treatment, conventional teaching, that patients with Eisenmenger survive for 15 to 20 years after diagnosis, and patients with idiopathic pulmonary hypertension are dead within the next 3 years. So this is possibly a recruitment bias, where these are not patients who are diagnosed on the day they enrolled in the registry. These are patients who are being treated with Eisenmenger for many, many years. So possibly some of these were caught when they were in their 40s, and so there was attrition. So this is really prevalence, and it's not when they were first detected. Factors associated with poor survival in this group: complex congenital heart disease, elevated creatinine, so renal failure, secondary changes in the other organ systems, right ventricular dysfunction, later age at onset of symptoms, worse functional class, evidence of congestive heart failure, abnormalities in their EKG, suggestion of renal dysfunction, clinical arrhythmias, and increasing escalating drug therapy. The associated complications with Eisenmenger are hemoptysis, bleeding disorders, gout, arrhythmias, paradoxical embolism, infective endocarditis and brain abscess, angina, stroke, renal complications. Now, this is an important slide, and this is from Current Opinion in Cardiology. This really differentiates the idiopathic from Eisenmenger syndrome, where I'm really not going to read out the slide, but you will have the slide available, and this is pretty important, I think, even from understanding the physiology, but also questions can be asked for you in your tests on how would you differentiate these two kind of patients. But just in short, the right heart function is often preserved in Eisenmenger. The prognosis is better with a longer survival. They are much more cyanosed as compared to idiopathic patients who are not cyanosed unless they are terminal or they have an atrial shunt. They often compensate, and so they are not as symptomatic initially as the idiopathic patients. They do not perceive that they're limited, whereas the patients with idiopathic often were normal till they develop the pulmonary hypertension. So they may be athletes and they suddenly realize that they can't do anything. So looking at survival in patients with Eisenmenger syndrome, if you look at the simple shunts versus complex lesions, so these are the patients with, say, a VSD or PDA, and these are the patients with, say, truncus or endocardial. Survival is much lower with complex defects, and there's a much more rapid fall off the curve. An X-ray may be pretty deceptive in a patient with Eisenmenger syndrome because the heart size is not typically very large. But if you look at the X-ray, there's peripheral pruning. If you look at a CT scan, the proximal MPA and the branch PAs are huge, and they're much larger than the aorta. In peripheral vasculature. To you, routine blood count and chemistry panel. When you do the routine blood count, you're looking at the hemoglobin and hematocrit and the iron status. So you want to look at transferrin saturation and ferritin. Iron patients. Next, you would perform a transthoracic echo, and that is a screening method. Why do you need the echo? One, to get an accurate anatomic diagnosis and to understand the morphology. Look at right and left ventricular as well as all the 4 valves and their function. Presence of 1 or more shunts. You want to look at valvular regurgitation and velocity of flow if there are obstructions present. Doppler allows for estimation of pressure differences, so between RV and RA, so that tricuspid TR gradient tells you an estimate of the RV pressures, and if there's no pulmonary obstruction, then that is an estimate of your pulmonary artery pressures. Important, PR gradient in diastole gives you a pressure difference between the pulmonary artery and right ventricle. Now, if you assume the right atrial pressure to be about, say, 5 to 10, and the RV end diastolic pressure to be around the same, your PR gradient actually gives you an estimate of what the pulmonary artery diastolic pressure is. So it's almost as important as following your TR gradient. So this is an echo of a patient with an ASD, and this is the apical 4-chamber view. You look, the right heart is huge as compared to the left heart. The RV is big, the septum bows into the LV, and the LV is really compressed and pancaked. This is, of course, not the best view to look at an ASD. You will look at an ASD in the subcostal views. However, this is an apical view basically to just show you all the 4 chambers and the relative sizes. This is a parasternal long axis view. You see the VSD here, a large VSD, and if you look at the color, it shows you that there's bidirectional shunting at the level of this VSD. This is a lesion that's often missed in childhood, and this girl was actually missed in 2 or 3 centers before she came to us. And if you see, this is an AP window, and it's often missed because this is thought just color bleeding because of Doppler. And this child had a big AP window, which can be seen in this view. And again, in parasternal short axis view, you can see the huge AP window between her main pulmonary artery and the aorta. So echocardiography is really vital for diagnosis of the congenital heart disease. And she was 13 when she came to us, so it's pretty bad that this was missed. Other indices that you use are TAPSE for right ventricular longitudinal contraction, not that. Some of which are more useful in the research laboratory than day-to-day following up of the patient. However, tissue Doppler is also important in looking at what's happening with the function and correlates with RV diastolic dysfunction. This diagram shows you a correlation between an MRI-derived RV ejection fraction. Next, catheterization. This is important for decision making. Most important in cardiac catheterization is vasodilator testing. And what is that important? First of all, what cardiac catheterization is really the gold standard in evaluating patients. However, there are always problems associated with cardiac cath that you have to be aware of. Now, in the modern era, cath for pulmonary hypertension has much lower mortality than was previously discussed. There was a paper from the UK which suggested a mortality of about 5 to 6%, and recently there was a presentation from our institution which showed a mortality of less than 1% in patients with very severe pulmonary hypertension. So really patients with severe pulmonary hypertension should only be catheterized in a center which is used to taking care of these patients. It's important to be aware of their severe pulmonary hypertension in the pre-op period, make sure they're kept well hydrated and they're not acidotic and they're not over-sedated. Anesthesia must be well aware of their situation, be ready with oxygen and nitric oxide, be ready with handling problems and expecting problems in these patients. That being said, what else are the problems associated with assessment of hemodynamics? There's a spontaneous variation of pulmonary vascular resistance in patients known, and it has been documented to be as high as 13% between different caths on the same patient. Secondly, snapshot hemodynamic studies. What do we mean by that? It means that if you're catheterizing the patient on April 17th at 9 a.m., you're getting the hemodynamics at that time. At that time, this child may be a little acidotic, there might be a little atelectasis going on, maybe he's over-sedated, maybe he's coming down with a virus. So it's really giving you what happened at that time under anesthesia. It does not tell you what is happening, what happened in the past 3 weeks. It doesn't tell you what happens when this child is running, crying, screaming, ill or not ill. So it's really it's just at that point in time. It's influenced by sedation, general anesthesia, stress, catecholamines, variations in CO2, so how sedated you are or how much you're hyperventilating the patient. It's often difficult to compare studies using measured versus estimated oxygen consumption, and not every center is very compulsive about using appropriate measurement of oxygen consumption. Next, assumption of pulmonary venous PO2 without actually entering the vein often overestimates QP and underestimates the PVR because, and sometimes if you do not accurately account for dissolved oxygen, this is a problem. Presence of PR reduces diastolic PA pressures and you may underestimate the PVR in these patients. There are special challenges and one has to be really aware of these while calculating hemodynamics in single ventricle patients before and after palliative repair in the context of Glenn's or Fontan's, with or without fenestration, with or without obstructions, pulmonary artery obstructions, presence of MAPCAs, BT shunts, if it's a SANO. So there are a lot of issues in all of these patients, and the person who's doing the cath must be fully aware of the structural anatomy of this patient and what has been done before. So who is operable? In a patient with biventricular circulation, if the PVR is less than 5 to 6 Wood units times meter square, and if the PVR to SVR ratio is less than 0.3, then it's thought that the surgical outcome would be favorable. Now, the borderline ones are those with PVR between 6 and 9 Wood units indexed and a ratio of 0.3 to 0.6. There's no absolute consensus, but really, once you do vasodilator vasoreactivity testing, if your PVR drops to under 4 and the PVR-SVR ratio drops to under 0.4, then it's likely that these people would have favorable outcome, but that does not mean you discharge them from follow-up. You will closely follow these patients up. In a single ventricle patient, if the PVR is calculated PVR indexed is more than 2 Wood units, then fenestration is definitely suggested. What do you do with patients with borderline pulmonary vascular resistance? Is there a target vasodilatory response? It's recommended that, conventionally when you do vasoreactive testing, you're only testing with nitric oxide. But in a patient who's intubated and a child with a shunt in a sedated or anesthetized child, it is recommended to do the vasoreactivity testing with 100% oxygen and nitric oxide. And it's seen that after doing that, if the PVR-SVR ratio is less than a third, or if there was a 20% reduction in the PVR from baseline with 100% oxygen and nitric oxide, these patients had a more favorable outcome after surgery. But how many of the congenital heart disease with shunts are reactive? In one study, it was seen that with idiopathic pulmonary hypertension, Acute vasodilatory response was much more, about 40, and much lower in congenital. Which is less than what is seen in other types of pulmonary hypertension. One of the strategies for repair suggested is leaving this small hole while closing the VSD, which acts as a trap door and allows for right to left shunting, at least in the early postoperative period for recovery. Now, what do you tell these patients? You do not want them to be couch potatoes. You want them to move around and exercise. You don't want them to be candidates for developing deep vein thrombosis. As it is, they have sluggish circulations and increased hematocrits. You want them to be active and walking around, and the goal as a physician is always to bring the patient to a situation where they can be independent and where they can have a lifestyle as normal as possible. So it's been shown that regular exercise improves quality of life overall. So they might need an exercise program which will work within their limitations. Avoid dyspnea, syncope, chest pain. You're not going to put them on some kind of competitive track. You want to work with them slowly and improve their exercise tolerance. Avoid physical activity after meals or if it's extremely hot or extremely cold. And remember, when they travel, suggestion of use of oxygen during air travel and avoiding climbing to high altitudes is important in this group of patients. Pregnancy in Eisenmenger syndrome is associated with a 50% mortality because there's an increased rate of spontaneous abortion and really mortality in the mother in the peri-pubertal period. So there's a lot of physiologic changes that happen in these patients just before delivery, at the time of delivery, and in the first 72 hours after delivery. And there are immense changes in the preload and afterload that goes on with the loss of this big placental area, which is afterload reducing area. And also if they have a C-section, there might be blood loss and preload drops. If they have a normal labor and over the next 72 hours, there's an immense increase in preload as all the peripheral edema and fluid get back into the circulation. So it's something that a patient should be completely counseled. And if they become pregnant, then early enough in pregnancy counsel of hormonal birth control has to be done with caution, and we suggest low-dose estrogen with care. Barrier contraception and IUDs are also recommended, but again, some of these patients have such severe bleeding disorders that IUD can lead to torrential uterine bleeds, and it may be a problem. Tubal ligation may be performed if indicated. Next, prevention of infection. Pulmonary infections are very poorly tolerated in patients with congenital heart disease and pulmonary hypertension. So establish a routine vaccination schedule for influenza, pneumococcal pneumonia in these patients. And if they have persistent fever, then one has to promptly evaluate for endocarditis. How do you manage their high hematocrit? Prophylactic phlebotomy is not recommended in asymptomatic or mildly symptomatic patients because it's known to increase the risk of stroke, increase risk of iron deficiency, and reduces exercise tolerance. What are the indications for phlebotomy? Moderate to severe symptoms of hyperviscosity and secondary erythrocytosis, and maybe preoperative phlebotomy for autologous blood transfusion. We don't necessarily routinely anticoagulate these patients, however, they are known to develop thrombosis. If we do anticoagulate them, we keep their INRs in the 1.5 to 2 range and not in the 2.5 to 3 range, like you would do that in valves. You would definitely anticoagulate somebody who's had a thromboembolic event, and if they have a prosthesis, or if they have atrial arrhythmias. You use diuretics to manage right heart failure and evidence of fluid retention, but you want to titrate them carefully to avoid dehydration. PAH-specific therapy. At least in the United States, no PAH therapy is approved for use in children, and it's only that we treat children with the same medications that are approved for use in adults. Calcium channel blocker therapy is not recommended in Eisenmenger syndrome because you could actually drop the systemic vascular resistance more than the pulmonary vascular resistance and increase the right to left shunt in these patients. It has been shown that use of pulmonary vasodilator therapy actually improves exercise capacity, and there has been an increase in 6-minute walk distance in patients with treatment for Eisenmenger syndrome. And these patients were treated either with PDE5 inhibitors, endothelin receptor antagonists, or inhaled prostanoids. Without advanced therapies, which are currently available, this was the extrapolated cumulative mortality curve over 7 years with no advanced therapies. And with advanced therapies, the mortality is less than 5% over 7 years. With olden times, with no therapy, the mortality was more than 35% at 7 years. So this is the improvement we've had in the past decade or so, with availability of several therapeutic agents. This was a study this was actually the first landmark study with use of IV epoprostenol in Eisenmenger syndrome. These were baseline hemodynamics, where you see the mean PA pressure was 77. With acute prostacyclin use in the cath lab, the pressures were not any different, but with chronic use, there was a significant drop in the PA pressures, improvement in cardiac index, very significant drop in PVR. So acutely, there wasn't that much of a drop, but this was about 20% drop. But chronically, the improvement continued. The same in saturations, there was no drop in the saturations with use of prostacyclin. So it was actually this study which stimulated and encouraged use of the same kind of vasodilator or targeted therapy in Eisenmenger patients as was used in idiopathic patients. The BREATHE-5 trial was a placebo-controlled trial of the endothelin receptor antagonist bosentan in patients with Eisenmenger. What they found was that there were improvements in 6-minute walk distance, which was continued over 24 weeks of therapy, and there was a reduction in PVR as well as PA pressures in these patients. The location of the defect did not impact on the improvements seen. This is the same thing in a diagram. This is use of sildenafil. This is from China. Use of sildenafil in Eisenmenger syndrome. Baseline to post-treatment 6-minute walk showed a significant difference in about 56 meters difference, which is quite significant. Oral sildenafil for Eisenmenger, this was another study from China, Zhang et al. Prospective open-label multi-center study with use of sildenafil, and they found an improvement in 6-minute walk, resting saturation, mean PA pressure dropped, and the pulmonary vascular resistance index dropped significantly. Use of ambrisentan, which is a selective endothelin receptor antagonist for congenital heart disease, pulmonary hypertension. It was seen that the 6-minute walk test increased in the first 3 months, but that did not seem to be sustained over 2 years. Again, coming back to the REVEAL study, this was time from diagnosis in years. So if you look at survival estimates, these were patients with operated congenital heart disease and idiopathic. The survival estimate in operated congenital heart disease was actually lower than idiopathic. The next and an important subgroup of patients who are increasing in number are the failing Fontan patients. So with advances in surgical repair, the prevalence of patients with single ventricles who have undergone a total cavopulmonary connection is increasing, And with time, these Fontan patients all start developing problems. The questions that we now are faced with are, can targeted pulmonary hypertension therapeutic agents help these patients with Fontan and make them, first of all, prior to surgery, prior to Fontan, make them better candidates? And those who are failing Fontans, can we reverse their problems? Because increased PVR is one of the causes for a failing Fontan. We don't know the answer to these, and various clinical trials that are being planned and conducted will tell us more in the next few years. Now, what about lung transplants? Lung transplant is reserved for patients with the end-stage disease. So usually you do not list an early Eisenmenger because natural history studies have told us that these people will live a long time and transplant will probably kill them off sooner. ECMO has been increasingly used, at least in our institution and several other institutions, as a bridge to transplant in these patients who are really sick. Novel therapies may be available in the near future, which may improve symptoms, quality life, and prevent or reverse the disease progression. There is still hope, and advanced therapies have opened yet another era of hope for these patients. A small subset of patients appear to benefit with use of these treatments prior to surgery. So here we are talking about those patients who are borderline pulmonary vascular resistance. Perhaps if we treated these patients for 6 months or so and then send them to surgery, they might improve. Clinical trials are really important to help us get answers, but it's pretty difficult to do clinical trial because the rate of progression of this disease is variable depending on what the condition is. The perception of quality of life is different because these people start off with self-restriction. Use of mortality or transplant is not a good endpoint because mortality is not early in Eisenmenger patients. So it's very hard. And large prospective, multicentric, multinational registries may be important to try and understand what happens to these patients over time. So we are almost to the end of the hour. I'd like to open this to questions. Anybody? No questions from the audience? All right, if there are no questions, I guess we should end the session. And if any of you have any questions, please email me. My email is ushask01@yahoo.com. You can contact me by email and ask your questions, and I can let you know. Good luck, everyone.